Hi, I'm going to kind of talk to you about the ins and outs of how we do risk assessment and the genetic process, the genetic testing process, which has really changed. I'm a doctorally prepared nurse. I'm faculty at St. Louis University, and I run the hereditary cancer program, and I've been there since 1999, so a long time, and I did this before that time. So it's been absolutely amazing for me to watch how this has kind of unfolded, even since the time I've been at St. Louis University, which is just now coming up on about 15 years. So we have a very unique program there in that we don't bill for my service, and so I see a real gamut of patients and whatnot. I do genetic testing and counseling for people with adult oncology, so I don't do pediatrics or anything else. I have a very limited practice, and I'm here today to kind of talk to you about what you should kind of think about and what you should know if you're going to embark on the genetic testing process. And I suspect some of you in here have already been through the genetic testing process and how things have evolved really a lot in the last 6 to 12 months and what that might mean for you. So in the big scheme of things, we know that about 10% of all cancers are associated with genetic risk. So we know that about 10% of the time when an individual is diagnosed with cancer, that is because they have something in their genetic makeup that was passed to them from, in most cases, either the father or the mother, and that put them at increased risk for developing the cancer. So even if someone tests positive for one of the cancer susceptibility genes, it doesn't mean that they'll get the cancer. And the key word is susceptibility. It means that your risk is greatly increased. And so we have had the ability to do some genetic testing for some things, like some of the thyroid things and that for many, many, many years. But in 1999, Myriad Genetic Labs introduced testing for the BRCA1 or 2. And you all think about that in terms of Angelina Jolie, because she's been all over the news about this, and she had one of those types of mutations. So they introduced that in 1999 and 98, 99, and that was about the time I started working at St. Louis University. And we did some testing in those early years, but a lot of people were very reluctant to do it because they were afraid of losing their insurance. Healthcare insurance was not paying for it real well. It was very expensive, so there was a lot of controversy as to whether or not people should test. And we would test some families there. And key indicators of hereditary breast and ovarian cancer syndrome are people who have a family history of breast cancer, especially breast cancer diagnosed before the age of 50, people with breast and ovarian cancer in their family. People of Ashkenazi Jewish ancestry are much more likely to have 3 specific mutations. So if they have a diagnosis of breast and or ovarian cancer, even without a lot of family history, we would offer testing to them. People who had bilateral breast cancer or bilateral ovarian cancer, meaning both sides were affected. Those were all people that should have been offered testing. And when that testing became available, we had some people that did that testing. Probably in the mid-2000s, testing became available for what we call Lynch syndrome. And I actually did my postdoc training with Dr. Henry Lynch at Creighton. And he contended all along that there were families who had a history of colon, uterine, ovarian, and probably breast and some other cancers, that they had these genes. And he and his wife, Jane, they were just the neatest people. They would, if you identified a family, they had this huge RV, and they would go to a family reunion. They were all over southern Missouri and southern Kansas, and and whatnot, and they would say, here's a family with all these different kinds of cancers, and they'd go to the family reunion and they collect blood from all these and they would analyze it. And eventually they became aware that there was something called Lynch syndrome, and it was associated with 4 or 5 different genes on different chromosomes. And ovarian cancer is kind of part of Lynch syndrome as well. So, you know, up until recently, when people presented with ovarian cancer, our big dilemma was, does this look like BRCA or does this look like Lynch syndrome? And in some families, it was really hard to tell the difference. So testing has changed a lot. And now we have the abilities to test for many, many other genes. And so I'm going to kind of talk about that in a few minutes, about where we are with testing right now. But the first thing you kind of need to realize is what's going to happen if you embark on genetic testing. Behind my name, there's a credential that says APNG, which means I'm an advanced practice nurse geneticist. So I have been trained and credentialed, and so I have passed boards in genetics. There are also master's prepared genetic counselors. And here in this region, and here in the St. Louis area, I'm at SLU. There's one at Cardinal Glennon with the SSM system. There's one at St. Luke's, and there are probably 3 or 4 over in the whole WashU system. So there are not that many of us who are credentialed genetic providers. But I cannot tell you how important it is that if you decide to embark on genetic testing, that you really get the counseling and the education before you do it. And it's important for many reasons. So first of all, that the right test gets ordered and that it gets interpreted correctly. We're all human beings, we can all make mistakes, but you decrease the chance of those mistakes a whole lot. So it is not just a simple blood test. There's been a lot of advertising out there. It says, oh, just get this blood test and it'll tell you. It's not that simple. If we don't order the right test or we don't interpret it correctly, we don't do you any good. So when someone calls and they want to talk to me about, you know, coming in, I usually ask them a little bit about their personal and their family history on the phone. And most of the time when people call me, they are appropriate for it. So they come in, and that first portion of the counseling is really what we call risk assessment. So, you know, I kind of ask them some questions about, you know, what their personal medical history is. And then we talk about their family history. Now, genetic testing is incredibly high tech, and yet the way we identify families is so low tech, it's not even funny. I have like this little template with circles and squares, and it's like a little ruler. And what I do is we draw out your family history. So I'm going to ask you a whole lot of questions about your family history. I'm going to say, well, you know, how many brothers and sisters do you have? And then I'm going to talk to you about each of their health. How many children do you have? I'm going to talk to them about each of their health. What about your mother's health? What about your father's health? What about all your paternal aunts and uncles' health? What about your maternal and grandparents' health? So we go through and we try to draw out at least three generations. Usually, if we can draw out 3 generations with some accuracy, we can kind of get a pretty good idea of what the chance is that we're going to find something if we embark on genetic testing. So genetic testing is not a universal thing. You don't just do it in everybody. We do it in families for 3 reasons. We do it, one, is there a reasonable chance we're going to find something? And 10 to 15% chance of finding something is actually considered reasonable. You know, from where I sit, it's kind of low, but we think if there's a 10 or 15% chance that we'll find something, and I have ways of mathematically calculating that, then we'll go ahead and offer you testing. Or you kind of hit some general criteria that we would generally offer testing for. The second reason to do genetic testing is there's someone like me who can explain the results, okay? So you don't want to do this unless you know that there's a support system behind you to help figure things out. And the third thing about genetic testing is that it has to change what you do. So I really don't want to order genetic testing in people who say, well, I just think I'd really like to know. Because you're going to learn stuff that maybe you just really didn't want to know. So you don't do it because you think, well, that'd be a cool thing to know. You do it because if I knew I had increased risks for having colon cancer in addition to ovarian cancer, maybe I'd get a colonoscopy every year or every 3 years instead of every 10 years. So on the other hand, I don't want to do colonoscopy, send you for colonoscopy every year if you don't need it. So sometimes genetic testing can really help us sort out what's appropriate. So we only want to do it if it's going to change your care or care of people around you. So the first thing we do after we draw out the family tree is then we kind of talk to you about what we think your risk for developing cancer or cancer is based on that family tree and the history you've given us, okay? And then we talk about what your risk of a mutation is, okay? And then we kind of all take a big step backwards and we say, okay, what's going to happen if I do genetic testing? Now, as I said, a few minutes ago, 10 years ago, the only thing we could really do was BRCA1 and BRCA2. Maybe 9 years ago, we added the Lynch testing, but that was testing. In 2000, it became covered by Medicare in 2012. There was a whole new panel added to the BRCA testing. So we have a lot of people that had BRCA testing in 2008, 2009 that didn't even have complete BRCA testing. It's important to kind of realize what you had testing for if you've had testing. So I see a lot of patients.
What's BRCA testing?
It's the BRCA1 and 2. And that's the one that's associated with breast and ovarian cancer. That's the one like Angelina Jolie had. And that's the one most people who have ovarian and breast cancer, they think about. And we used to think that was about 85% of hereditary breast and ovarian cancer. We now know it's probably less than 30%. So we have a lot of people out there who did genetic testing for the BRCA1, BRCA2, and they're negative, and they say, well, I don't have to worry about it. You do have to worry because you'd had very, very less than complete testing.
When you said that BRCA testing is different now than it was.
Well, they're always adding things to it.
Well, I was tested in 2007 and I was positive.
You're right.
I do have the genetic.
Right.
Okay, so
would we do more in you?
Is there more to learn if I go back and do it now, or it's just like I maybe would have been negative now and now I'd be positive? I don't know what you mean. Like,
Well, if you were negative before, you might really be positive. If you're positive, you're still positive. It's that.
Okay, but
that
you're not going to learn positive plus or anything if I go back.
Probably not. But the one thing.
As far as my,
But the
as far as
one
my
thing,
children.
the one thing that probably has changed some since 2007, and at the bottom of our letters we always write, check back with us every 12 to 18 months, is that we used to think, well, the BRCA1 or the BRCA2 was really only associated with breast and ovarian, and we now know that the pancreatic cancer risk is elevated.
I could have gone all day.
I know, and I thought before I said that. Don't worry, it did run through my brain before I said that to you. So in some of these families, we have gone back and recommended they do some pancreatic screening, and so that is one of that's like a really big take-home point from today. Whether you do genetic testing and you've been positive, or if you're negative, that checking back periodically is important, because it's like an exploding science. It's what held in 2007 in terms of what we were probably counseled. I would hope for in 2007 would have been that your risk of breast cancer once was about 90%. Risk of a second breast cancer would have been 65%. And that the risk of ovarian cancer ran between 40 and 50%. And I see are you a survivor, I'm assuming? Yeah, so I'm assuming you took care of your ovaries. I'm assuming they're like long gone,
I did, but you know what, I could kind of be a commercial for this, because I went in because my sister was an ovarian cancer survivor, and they found the genetic mutation, so I went in for a prophylactic hysterectomy.
And they found it.
And they found it.
Right, and that happens in about 10% of the cases, actually. But we find they have a little early something.
I was diagnosed early.
Right, you were one of the very fortunate ones. Right. So that part of the counseling probably hasn't changed since 2007, but what we know about the risk for other cancers has changed a little bit. So when we talk to families now about genetic testing, it's much more complicated. So I see families who have tested negative in the past, and usually it's for the BRCA1 or 2, sometimes it's for some of the Lynch syndrome, and they're still worried about their risk. Or what happens, I think, a lot of times is, you know, their kids kind of get to an age where they're worried about their risk, and they're like, what should we do? So, you know, one option is to kind of go back and kind of test for things that were not available. So, you know, historically what has happened was last August, the marketing or the billing kind of thing for the BRCA testing really changed because Myriad lost their patent for the BRCA1 and BRCA2. And when you had your testing, and now I'll use you as an example, which is probably very bad, but when you had your testing, there was only one lab in the United States we could send it to. So we always sent it to Myriad. And they lost their patent. And those of us that worked in genetics kind of sat there and in some ways kind of waited for it because we hoped that it would bring the cost of testing down. And it has brought the cost of testing down some. But what also happened at the exact same time, which was kind of, I guess, serendipitous, was that the ability to run, the technology for running genetic testing changed. When you had it done, it was done through something called Sanger sequencing, which is very good, but it's kind of a slow process. They can only do little pieces of genetic material at a time. And in the last 2 years or so, something called next generation sequencing has come along. So it's just a different technology. It's a new platform for how we do testing. And they can test for lots of genes with a small piece of genetic material. You know, so in the time it took to run the test for the BRCA1 and BRCA2, you can now run the test for 15, 20, 29, 30 genes, maybe more than that. So that really changed how we do testing, okay? Because now there's a lot more choice in what you do. So my strategy now when I see patients is they come in and we draw out their family history and I talk to them about their personal history. And what families don't realize is the more information you give me, if you give me good information, I'm going to be able to give you way better information back. And so sometimes patients will call and they'll say, well, I want to get seen tomorrow. And I'm like, well, I could maybe see you tomorrow, but if you don't bring me the right information, I'm not going to do a good job helping you. You know, so sometimes kind of stepping back and trying to really get a good family history is very important. So we bring families in, we look at their family history, and then I kind of think about what syndromes genetically am I worried about? What things am I, you know, what do I think is a possibility that they could have? So it's not a one-size-fits-all anymore. If someone comes in and they you know, maybe they're a you know, Ashkenazi ancestry, and they have one family member with ovarian cancer, and they were diagnosed with breast cancer, I might order a breast and ovarian panel of 21 genes from one company. So I'm ordering, it's like casting a wider net. I like to fish. So if you fish with one line, you're only going to get them in one at a time. If you put a net out there, you're hopefully going to get a whole bunch of fish all at once. So it's changed the way we order. We don't just order one thing and then we're done. I know there was a question somewhere.
What happens if somebody comes in but they really don't know their family history?
Well, then we do the best we can. People who are adopted are very challenging for me. Sometimes you can get it covered if they don't know their family history, and sometimes you can't. When we don't know the family history, it makes it harder for us to interpret the results about what that risk really means. We'll do the best we can, but I'm going to tell you that, you know, I think this is what's going on, but I can't be as sure because you're not as sure, you know. So it's a limitation. It's not a thing that keeps us from doing it necessarily. Does that kind of answer your question? Okay. So now I'm going to sit there and say, okay, I'm going to think about ordering this. Maybe for this person, I think 21 genes is, for this breast and ovarian panel, is important. Someone else might come in and they have some family history of colon cancer, or maybe they have kidney cancer or something. I might order a different panel of genes for that particular family. So it's not just like you just check the box and order the whole thing. You really think about it. So the hard part about this approach is that we'll go back and just embarrass you again. When you had testing, I would hope that you were told that if you test positive for the BRCA, that they're going to recommend preventative mastectomy, and that recommend you have your ovaries out when you're 35 or 40 years old or whatever. We could kind of tell people, if you're testing for a single gene, you can kind of tell people, if you test positive, this is kind of what the general train of events will be. When you test for 10, 15, 20 genes, you can't really explain each possibility up front. So people have to kind of be able to realize that you're going to do this testing, you're going to cast this wide net, and then you're going to have to come back, and when the results come in, then we're going to have to sit down and really think about how to manage it. And that's one of the reasons it's more critical than ever that you really be seen by a geneticist, because the interpretation of these tests is way more uncomplicated than it is when you're just doing a single thing. So we kind of talk to families about that. We talk to families about what tests we're going to order and why. We talk about the process of genetic testing. In most cases for these big panels, it is blood as opposed to saliva. When you're testing for one or two things, a lot of times we can get by with saliva. When you're doing a whole lot, usually we need to poke you. There are some exceptions to that for my really needle-phobic patients, but generally it's blood. You'd send off these tests. It's usually about 3 to 6 weeks for results. So it's not like they come back, an hour later. You're going to send this, and then you're going to wait a while. And even waiting longer than 6 weeks doesn't necessarily mean anything is bad or going on. It is what it is. The next piece of the strategy that we talk to families about are, well, what are the risks or the problems with testing? It used to be people worried about losing their health insurance. That's against the law. If you have group insurance and you're trying to get Obamacare, they can't ask you if you've had genetic testing before in the past. That's against the law. And so that's helped a lot of our patients, because a lot of our families years ago were reluctant to do this because they were afraid they wouldn't be able to move jobs or things like that. But there is still a risk of having a higher life insurance premium, and it can sometimes make buying more disability or like long-term care and nursing home insurance a little bit more expensive. So I talk to people about that before you test. Maybe you want to buy more of that in some cases before you test if you're in a position where you can do that. If you've already got the ovarian cancer, it doesn't matter. But if I was testing one of your kids who didn't have it, I'd have a long conversation with them before I did that. And that's another reason to see a geneticist, because we know to do, that's like part of our general operating procedure. I think one of the biggest limitations of testing is sometimes we can do all this testing. We can test you for 20 genes and still not find it. Now, that doesn't mean that you don't have hereditary risk. It just means you tested negative for those 20 genes. And then we kind of have to manage you based on your family history and whatnot. And maybe 10 years from now, there'll be more we can test you for. But right here and now, it's still kind of non-informative. The other thing that has happened a lot with the panel testing is that we have a lot more what we call variants of unknown significance. We test you. You have a change in your genetic material, and we're not sure what it means. We're not sure if it's associated with increased cancer risk or not. Now, sometimes the labs will do free testing for other family members who have the cancer to kind of try to sort it out within the family. But you don't always get immediately helpful information. And we would see some variants when we would do single-site testing, like for BRCA or Lynch. But if you start testing for 20 genes, you kind of have 20 times the chance that you're going to, have a variant. Now, eventually we sort those variants out, but not always immediately. And that can be very, very distressing for families. So my policy generally is for people to come back in once we have results available and kind of talk to them about what they mean. And then depending on the specific gene, we'll say, well, this gene is associated with a 40% chance of breast cancer and a 60% chance of ovarian cancer or a 80% chance of colon cancer, and this is the best way to manage this to prevent or to really reduce your risk for these cancers. I can't make those recommendations till I know what you're positive for. And then, another important reason why you want to see a geneticist is that once I find something in someone, then we need to coordinate care for the rest of the family. Now, it sounds like, was your sister tested before you were tested? Is that how? So,
She was diagnosed.
And you had a known mutation. You were tested for a known mutation.
Yeah, because I only had that.
You had the single site. You had the little bitty single site, which is like $300 or $400 as opposed to $4,000, $5,000, right? Yeah. So once we find something in a family, it doesn't do any good unless we make sure that the rest of the family knows that they're at risk and that they get the right test ordered for them. And there's all kinds of nuances as to how that does. So that's one of the big things I do if someone tests positive. We talk to them about what that means for the person we tested, and then we talk to them about who else in the family needs to be informed and get in and see me, or if they live in Timbuktu, then I find someone like me wherever they live. And so that's a big part of my day is coordinating care for a lot of other people. It's important to realize that a lot of times that, when you test positive for something, it may not just be like the ovarian cancer. There may be risk for breast or colon or other cancers. So that kind of catches people by surprise sometimes. So they think, oh, I'm done, I don't need to worry. And then all of a sudden it's like, oh, I do need to worry. It's much more complicated than I thought. Yes? Sure.
The first one, if you turn out to be around 1.2, is that associated with a certain type of ovarian cancer, like serous or germ cell?
We don't really know. We know that the risk is probably it's probably in the range of 30 to 50%, and the population risk of breast cancer is like 1 to 2% depending on who you read. So there's a huge increased risk, and anything, knowing that your risk is 30, 40, 50% for a cancer that's hard to detect early, we're going to talk to these families about prevention. Certainly people are watching it, but there's not like, it's not like, oh, you have this kind, we know you're at increased risk. Now, in terms of BRCA testing, we know that women that have a type of breast cancer called triple negative, it's negative for estrogen, progesterone, and HER2/neu, that they are more likely to be BRCA positive. So one of the Medicare criteria for testing is triple negative breast cancer diagnosed before the age of 60. You don't even need any family history in Medicare. We'll pay for it. So we're not quite there with ovarian cancer. That's a good question. It's coming, but not quite there yet.
And the other one is, since there have been leaps in medical care for colon cancer, maybe colonoscopy.
Right.
What if you had colon cancer and most recently everybody around you had diverticulosis and diverticulitis? Would that be the mutation? You're more susceptible? Or?
If we test you for something and it's associated with increased colon risk, we're going to make a recommendation based on the test, not necessarily the family history. The family history will play into it, but we're going to make that recommendation. If you tested for one of the Lynch genes, like the PMS2 gene, you have an 80% chance of getting colon cancer if you don't have annual colonoscopy. Okay? Because people with this particular mutation, they can go from a polyp to a colon cancer in 12 to 18 months, whereas most people, it takes 7 to 10 years to go from a polyp to a colon cancer. That's why the general guidelines in the general population are colonoscopy every 7 to 10 years. And 10 years is really pretty much okay for people in the general population. But if you have that mutation, you need annual colonoscopy. You also need upper endoscopy and some other things. If you had a mutation that we knew was associated with increased colon risk, we would go ahead and treat you, screen you very aggressively. It's sometimes hard to understand. Families don't always, a lot of times I'll ask families, I'll say, well, is there a history of colon polyps in your family? Because that's an indicator of some of these syndromes. And sometimes people have no idea. Or they're like, my mom and dad never had a colonoscopy. You're never going to know. And, so we have to base it on both the history and what the testing says. A lot of times the testing gives us a lot of insight.
I was tested positive for the BRCA2
Uh-huh.
and I have ovarian cancer, breast cancer, pancreatic cancer, and skin cancer.
Yeah, you've done the right.
And all those were my mutations. So
BRCA2 can be associated with increased melanoma.
So I had a bilateral mastectomy June 26th.
Okay.
And I go see, they send me over, I see a dermatologist every year. So I have different specialists since I had the testing done. They make appointments for all those different specialists.
Right, and when someone finishes, after they do genetic testing in my office, after we get the results back, I give them another copy of the test results, but I also send them a letter that says, this is what we found. These are the people in your family that need to get on the stick, and this is what I'm recommending specifically for you. And if you had ovarian cancer when you came in, I'd say we're recommending bilateral mastectomy because your chance of breast cancer is 90%. I'm going to recommend you see a dermatologist once a year. We'd probably tell you colonoscopy every 5 years instead of every 10. We would have said, we would have probably now we are recommending pancreatic screening for some of our BRCA2 patients' specific mutations. And we also talk to people about the importance of diet and exercise and not smoking and not drinking to excess and things like that. So I'm going to send people a very specific letter tailored to them that then they can give to all of their other doctors. And if they can't figure out who all these people are, then I'll say, well, you can see this person, and we coordinate all that care for you. It doesn't do any good to do genetic testing if you're not going to follow up with it. So that's my whole thing. If families say, well, I'm not going to do anything different, then I'm like, you shouldn't test because it's not going to change your care, But for you, I think it's been life-changing.
Yes, it has.
And probably in a very good way.
Like since I've tested positive, my sister, I have 5 sisters.
Oh, yeah, you're keeping somebody busy.
Yeah, so each one of them has been recommended that they have their ovaries removed.
Have they all tested positive?
One did the test, the other 4 was like, I don't want to do it.
Well, see, and when you go to single site testing, now they did a lot of testing in you, I'm guessing. And then when we go to single site testing in the other family members, that can be such a blessing for family members. So if statistically we would guess that about half of your sisters would have it and half wouldn't, that's the statistical. Now they all might have it, or none of them might have it, or one might have it and 3 might, or it can be all different kinds of combinations because it's 50-50 chance for each one of them. But
She doesn't have a mutation.
right, so she really wouldn't need to take her ovaries out because her risk of ovarian cancer is that of the general population. She would still need a pelvic exam every year. She'd still need a mammogram every year starting at 40. She'd still need colonoscopy every 7 to 10 years starting at 50. But she wouldn't need all this revved up stuff. And so, earlier this week I tested 2 daughters. They were of a woman with ovarian cancer, and they had a Lynch gene, and the 2 daughters were in their mid-20s. They were twin daughters. They were fraternal twins, and so I think they were about 24 or 25, and there were some very young cancers in this family, and they had reached an age where they would need annual colonoscopy. So they came in, and they wanted to be tested together. They're twins. They're very close to each other. So And the mom came back with them, and we sent their single site several weeks ago, and they came back. I said, you got to come back and get the results. And it turned out that both of them tested negative. So these two women did not inherit what their mother had. Well, I can't even tell you the party that was going on in my office. And it was just joyful for me to watch, because they know that they didn't inherit it. They know that they still have the regular people risk for developing cancer, but they don't need to go have a hysterectomy when they're 40 years old. They don't need annual colonoscopy. It would be a waste of our resources to do that. So for them, single site testing was really positive. Earlier in the week, I had a woman that whose daughter tested positive for a BRCA gene, and for some reason, everyone in this family had breast cancer by the time they were 30, and she's in her early 20s. And she's a really mature and head on her shoulders, just grounded kind of a young woman. And she said, if I test positive, I'm going to really do prophylactic mastectomy, because everybody in her family has had breast cancer by the age of 30. And she tested positive, and I talked to her last night, and she said, I'm okay. She said, because she goes, I know now that I can control my destiny. And she's wise beyond her 20-something years. But so we can really use this to save people's lives and to help them not do excessive things that they don't need to do, so it's very valuable.
Can you talk a minute about how people are banking their blood for?
DNA banking, and we recommend that sometimes. We don't recommend it tons of time, but we do recommend it, and there are several kinds of different ways to do it. If someone has a strong family history of cancer, and frequently it's for people who are kind of terminally ill, is where I see it done most often. And we maybe have not been able to identify a mutation, but with the family history is such that we think that it's really there. We encourage families to perhaps bank a specimen, and we can arrange for that, and there's some yearly cost involved, and depending on how much you want to bank and how long you want to bank, it drives the cost. But we do have family members that bank blood because they're hoping that in time they're going to figure out what happened. I also have families who enroll in research studies that are kind of unending, so that their blood is kind of, the Cleveland Clinic has some huge studies where they're doing all sorts of genetic sequencing, and if they find something down the line, they will tell us. And so I have families that do that as well. It's an option, and it's a good option if you think the person who has the malignancy is not going to live long, and who kind of has the answer in their blood, but you want to save it. So that's a good option.
I myself an ovarian cancer survivor. I have a history on both sides of the family of colon, thyroid, lung, uterine, breast, and
Yeah, we'd see you.
cancer.
Yeah, we'd see you.
And I have one ovary left because I was lucky. My cancer was contained.
It was a very, yeah.
So.
But we would see you. We would offer you testing, and then depending on.
I also have a fraternal twin sister who has 2 girls, and I have a daughter.
Right, so we'd offer you testing, then you could see what happens, then you could make decisions about what you want to do,
I've already been recommended to take the other ovary out.
Well, a lot of people say that might just be a good idea, but if you were genetically tested for something that you knew that was a good idea, it makes you more comfortable with the decision.
Yeah, it's almost 100% gonna happen. It's just figuring out the time frame.
Right, and you're probably at a good point in your life to do genetic testing, because you're not in active treatment right now. You can kind of sit and think about it, and it really may change care for your sister and for other people. Because if your sister could avoid that, that'd be a good thing.
Yeah.
Yeah, of a lot of the cancers I test for, ovarian's the one. We have people who they're all worried about their breast cancer risk and who are BRCA positive, and I'll tell you, I worry way more about the ovarian risk with the BRCA than I do the breast, because I'm like, we have some good screening for breast cancer, and we have some great treatment for breast cancer that people tolerate. Whereas the ovarian cancer, we don't have the magic screening test yet.
Yeah, I didn't have normal symptoms.
No.
I went for a regular exam.
Yeah.
And they found the mass.
Yeah, I mean, there is, so we're not there in ovarian cancer yet. So for me, that's one of the I'm pretty, I'm like, you're 40 years old. I would recommend that you take your ovaries out if you have that kind of risk rather than waiting.
I'm almost there.
Yeah. Please call me. I'd be glad to. I have cards up here later if any of you need a card. You have a question?
Dr. Megan, does age, get it, make a difference?
Certainly anyone diagnosed under the age of 50 that's a key indicator for colon, ovary, uterus, breast, any of them. And in fact, most of the Medicare criteria for testing, if you're under 50 for any of those cancers, 50 or under, they'll pay for it even without a lot of family history. So, that's one of the ways we kind of look at who's appropriate for testing. Yeah, good question.
So, will insurance sometimes pay any of it?
I'm pretty darn successful with getting insurance to pay for it because we've done the assessment. We have the, I'm not going to send testing, like some practices just send it on everybody. No, it won't get paid for because it's not, it's really not appropriate. And a lot of times I'm pretty successful because people call. I have a lot of women in their 20s and 30s and they're like, my mom had breast cancer when she was 35 and I want to get testing. And I'll be like, is your mom alive? And they'll be like, yeah. And they're like, I want testing. I'm like, it's better to test your mom first and then test you. I can probably get it covered in their mom. And then once I prove the mom has something, then I can get that single site covered. So a lot of it's just about really testing the right person and doing it in the right order. And we really think about who's the best person to test in this family before we do it. I would say most of the time I get the copays to under $100 if they have private insurance. If they hit Medicare criteria and they're on Medicare, it'll be covered 100%.
If I test positive, at what age should my daughter get tested?
Depends on what you tested positive for, okay? We have a few things where kids can get into trouble with stuff in their teenage years, not often. But we have a few colon syndromes where they can get into trouble in their teenage years, so then we're going to test them younger. It's one of our exceptions. Generally, we say in their mid-20s for most of the things I test for, but we also look at the youngest age someone was diagnosed. So if people are getting diagnosed with stuff in their late 20s, I'm going to be wanting to do that in their early 20s because you want to.
I was 31 when
Right. So.
I was the youngest.
Right. So. Early-ish 20s, we kind of use a 10-year rule, So I'd say certainly by age 25 and probably earlier than that, depending on the maturity of the kid. We used to say when they graduated from college, but there's so much failure to launch now that, that's not a good way to, We used to say, oh, they graduate from college and work for a year. That doesn't work anymore because, now they're all 30 before they set their foot into their first job. So, a lot of it's a maturity thing, And a lot of times when that kind of comes up and we're testing younger people, my recommendation is they come in, we talk about it, we talk about what they might need to do, like maybe you need to go buy some life insurance or maybe you need to do some of that. Go home and think about it. Do you really want to know and are you going to be ready to do something? And then they'll call me back 3-6 months later and they're like, okay, now I'm ready. I've thought about it. I've talked to my boyfriend about it. I've bought my life insurance and then come in and see. I mean, I'm really not a big proponent of people come in and they get their sleeve rolled up and they're like ready to go. Sometimes people are ready to do that, and like if you came in and you had thought about it and you were really, you might be ready after one appointment, but a lot of people aren't. There's not we don't bill. I don't care how many times you come back.
It's going to happen.
Right, yeah, no, so it's different people are at different places. And there is not a one-size-fits-all. That's probably the coolest part of my job is I get to meet all kinds of people at all different points in their life and, no two ones are the same. So that's what makes my job interesting for me. But it's also a challenging thing because I can't, we really do have to meet you wherever you're at and whatever's best for you. Questions? Oh my gosh, is this where I'm supposed to be time-wise? Oh my goodness.